Good afternoon, everyone. So today we're going to talk about the pelvis, the hip, and the thigh, and pathologies and conditions that are prevalent within those regions. Um, to preface that, it's a little bit more difficult to do the hip, and so the process often requires referral. So in these slides, we're going to go over injuries for sure, signs and symptoms, not so much management because those things are usually referred out. But a lot of these are a little more hands off for what I do. And so, from the perspective of athletic training, we're going to be a little more concise. But let's go ahead and get started. The slides are sent to you as well. On slide 2, we're looking at the pelvis. So the pelvis or the pelvic girdle consists of a protective bony ring formed by 4 fused bones, the 2 innominate bones, the sacrum, and the coccyx. So the innominate bones articulate with each other anteriorly at the pubic symphysis, and then with the sacrum posteriorly at the sacroiliac or SI joints. Each innominate bone consists of 3 fused bones, and they are the ilium, the ischium, and the pubis. Among these, the ilium forms the major portion of the innominate bone, including the prominent iliac crests in the front and in the back. So the anterior superior iliac spine, or the ASIS, is readily palpable, and it's a landmark on the iliac crest. The posterior superior iliac spine, or the PSIS, typically is marked by an indentation in the soft tissue, just lateral to the sacrum. So if you hear the term that someone has back dimples, they're talking about where the PSIS is articulating there. The pelvis protects the enclosed inner organs. It transmits loads between the trunk and the lower extremity, and it provides a site for a number of muscle attachments. On slide 3, we're looking at the hip itself. So the femur is the longest and largest and strongest bone in the entire body. The hip is the articulation of the concave acetabulum of the pelvis and then the head of the femur. It is it's a classic ball and socket joint. The acetabulum angles obliquely in an inferior, anterior, and lateral direction. Because the socket is deep, it provides considerable bony stability to the joint. So it is a ball and socket joint much like the shoulder, but it is not like the shoulder because it is much more stable. Both articulating surfaces are covered, the acetabulum and the head of the femur are covered with a friction-reducing joint cartilage. We have the acetabular labrum here. The cartilage on the acetabulum is thickened around the periphery, where it emerges with the U-shaped fibrocartilaginous acetabular labrum. So that further contributes to the joint stability. So we are going to talk about the labrum today. That is one of the injuries that we're going to cover, so it's important to know that. So in the picture on the slide, you can see the femoral head, where the acetabulum is, what that labrum looks like, and where it lies around the joint. And then also the ligament of the head of the femur. On slide 4, we're looking at the ligaments of the hip. So these are important to know here, but they're individual, yes, and so important to know, not so much in relation to specific injuries. So we'll go through them, and they will be right here for you to look at and reference along with the picture on the slide, but not so specific in when we get into the injuries. So several large and strong ligaments support the hip. The anterior aspect of the hip includes the extremely strong Y-shaped iliofemoral ligament. And so that is on the picture. You see the Y shape that it has there. There's also the Y-shaped, we just did that. It's sometimes referred to the Y ligament of Bigelow. I don't know why, but it is. It extends from the anterior inferior iliac spine, so the AIIS, and then it goes into the intertrochanteric line on the femur, so enabling it to limit hip hyperextension. Next, we have the pubofemoral ligament, which is also located anteriorly. It connects the pubic ramus to the intertrochanteric line. This one limits abduction and hyperextension of the hip. Then we have the ischiofemoral ligament, which reinforces the hip posteriorly, extending from the posterior acetabular rim of the ischium in a superior lateral direction and attaching to the inner surface of the greater trochanter of the femur. The spiraling nature of this ligament causes it to limit extension of the hip. Tension in these major ligaments twists the head of the femur into the acetabulum on hip extension, as occurs when a person rises from a seated position. Within this joint, we also have the ligamentum teres, and this one we're going to talk about in injury specifically. And this serves as a conduit for the medial and lateral circumflex arteries, but provides little support to the hip joint. So more importantly is that it conjoins with those arteries. Then we have the inguinal ligament, which runs from the ASIS and inserts to the pubic symphysis. It contains the soft tissues as they course anteriorly from the trunk to the lower extremity. And also the inguinal ligament is going to be important when we look at the femoral triangle, which we're going to do next on slide 5. So the femoral triangle is formed by the inguinal ligament superiorly, the sartorius laterally, and the adductor longus medially. And so when you anatomically look at it, it forms a triangle. And there's really important structures that go through that triangle. So when you are doing your assessment and palpation, keeping that triangle in mind and noting the structures that go through it are really important. So the region is significant in that the femoral nerve, femoral artery, and the femoral vein are all located within that area. The femoral pulse can be pulsated or palpated as it crosses the crease between the thigh and the abdomen. And then in addition, with an infection or active inflammation in the lower extremity, enlarged lymph nodes might be palpated in that region as well. So the femoral triangle is more for you to know when you're palpating, and then what structures you're looking for when you're going through those. Slides 6, 7, and 8 are more reference for you all. Those are muscles of the pelvis, the hip, and the thigh. Slide 6, we have an anterior view of those muscles. Slide 7, we have a lateral view of those muscles. And then slide 8, we have a posterior view. So those can be referenced for you as we're going through the slides, but we don't have to go through all of the muscles specifically. They're fairly large groups of muscles, and you should be familiar with them after the other classes that you've had. All right, on slide 9, we're looking at the kinematics of the hip and the major muscle motions that we're looking at. So because the hip is a ball and socket joint, the femur can move in all planes of motion. The massive muscle crossing the hip tendon to limit range of motion, however, particularly in the posterior direction. So it has a lot of potential for motion, but the ligaments and the muscles are so strong that cross that joint that it does not always demonstrate a lot of motion for most people. So we're looking at pelvic positioning. During many activities, the positioning of the pelvic girdle facilitates motion of the femur at the hip. And so we can assess for pelvic positioning. It might be part of the problem when we're looking at injuries. But that is something that I know at a fairly basic level. Looking at ASIS, are they in line? Looking at PSIS, are they in line? Or is there a little bit of a difference there? And we'll talk about that a little bit more, but that would be more of an indication of injury. It's not something that I would diagnose. When we look at flexion of the hip, the major hip flexors are iliacus and psoas major. And those form the iliopsoas. So if you talk to someone about having a psoas release or the iliopsoas is tight, that's what we're looking at, the major hip flexor that goes across the front of the hip. Then we have extension. Gluteus maximus and the 3 hamstrings are responsible for most of the hip extension that is happening. Abduction, we have gluteus medius, which is the main abductor. And then for adduction, we have adductor longus, adductor brevis, and adductor magnus as our main actors there. There is some slight medial and lateral rotation of the femur. And then the ones responsible for those are piriformis, gemellus posterior, gemellus inferior, obturator internus, obturator externus, and quadratus femoris. So those are the main actions of the hip. And then when we go through range of motion at the end, we'll talk about ranges and degrees of motion for those. So we're going to move into pathologies of the hip, and we're going to start on slide 10 with contusions. So there's a few different kinds of contusions that we can get in this area. We've talked before, a contusion is a direct impact to soft tissue, such as a kick to the thigh or a fall onto a hard surface. It causes a compression force, which crushes the soft tissue. The condition could be mild and it can resolve on its own in a matter of days, or the bleeding and swelling can be more extensive, resulting in a large, deep hematoma that can take months to resolve. Contusions can occur anywhere in the hip region, but they're typically seen on the crest of the ilium or in the quadriceps muscle. And so that's what we have pictures of on the slide. The picture on the left, that is called a hip pointer. A hip pointer generally refers to a contusion of the iliac crest over the TFL muscle, the muscle belly, with associated hematoma. But the term can also be used to identify tearing of the external oblique muscle from the iliac crest. But more than likely, a hip pointer is going to look like this. It's a big bruise that occurs on the hip. These can take a long time. Rest, ice, sometimes crutches are necessary. The person might not be able to weight bear. And then when they do return to sport, you could have protective padding on the hip. These are very common in volleyball. I've seen a few in soccer, baseball, softball with sliding, and then football as well. I've also seen them from recreational things. Slipping and falling and landing directly on the hip will also cause a hip pointer like this. When we're managing these, we want to keep the swelling as minimal as possible, so NSAIDs would be important to use there as well. The 2 pictures on the right of the slide are quad contusions. And so, well, the top one is mostly only a quad contusion, and then the next one, the bottom one, is what we will talk about next. So quad contusions, you get kicked in the thigh and you bruise. If the contusion is located, it's generally located in the belly of the muscle, and so it can bruise, it can swell, you can get a muscle spasm, lots of different things can happen, and then severity of the injury is almost always underestimated, which means it's not always treated correctly. Signs and symptoms here would be pain and swelling. They may be extensive immediately after impact. Sometimes passive flexion might be really uncomfortable, or active flexion would be uncomfortable as well. People will call it a Charlie horse, maybe, and they would get, they would say it feels like a cramp, but it's not cramping. It could also be palpable. You'll be able to feel that the body is trying to protect itself there, and so the muscle is spasming or you have guarding happening. So management for this, in the first 24 to 48 hours, you would use ice and compression. And then we're going to talk about management of strains later, but we'll talk about all of that on a different slide. So ice and compression, you want to stop the inflammatory process, and then the body will respond to that as well, which leads us into myositis ossificans. We talked about this a little bit before. It's an abnormal ossification involving bone deposition within the muscle, and so if you're repetitively hit, it's your body telling itself, hey, we need to protect this a little bit more. It starts depositing calcium in that area, which then makes a bony calcification within the belly of the muscle. And so that is what the picture on the bottom right of the slide is showing you, that little growth of bone in the middle of the muscle. And those can be very uncomfortable. Sometimes they have to be surgically removed. And then they don't resolve. So you can sometimes use ultrasound to break them up, but we want to treat them ahead of time so that they don't happen. But like I said before, the extent of a quadriceps contusion is sometimes underestimated, and so then those things are missed. Okay, so I had to reset. I got a little bit interrupted, so we're going to start in on slide 11, management for a quad contusion. First and foremost, ice and compression. The picture on the slide shows how you will ice and put compression on a quad contusion. So you want to do this on a stretch as often as possible when you have a contusion. It allows for the muscle to not spasm so much, and then it allows it to be in a stretch position so that the hematoma does not inhibit range of motion. So what you're looking for is to have pain-free, passive, and active range of motion. And then, like I said before, we're using NSAIDs as well to keep that hematoma from forming. Through the subacute phase, we're continuing to use cryotherapy and passive range of motion. You can use active range of motion if it's pain-free, and then also PNF as well if there's no pain. Swimming is really good for this. It helps the lymphatic flush through the body, but also with gentle kicking, it's activating those muscles without a ton of force going through. You can use an effleurage massage in this case of a contusion to help kind of flush out that the fluid underneath as well. For the final phase, you can start cycling and light jogging or running. You can use ultrasound in this area because the inflammatory process has stopped, so you can use the heat and the continuous ultrasound. That's helping to rule out myositis ossificans. And then return to play, you want their range of motion to be normal. You want to have bilateral equal strength and endurance, and then they need to be able to perform their normal sport activities, and so jumping, starting, stopping, changing of direction, whatever that might be. And then you might want to consider protective padding to prevent a myositis ossificans from happening. If they're kicked or if they're hit continuously in that same area, it can provoke that process to happen. So slide 12. We've talked about bursitis before. This can happen in the hip as well. The picture on the slide shows the different bursa that are in the hip and the pelvis region. So we have greater trochanteric bursitis, iliopsoas bursitis, ischial bursitis, and then we also have snapping hip syndrome. So this is common in runners and joggers, and it typically affects the greater trochanteric bursa, the three that are in the picture that we just talked about. The most common mechanism is inflammation secondary to excessive friction or shear forces caused by overuse, which is why we see it in runners and joggers, because it's that continuous motion, and they do it for long periods of time and almost every day. A second mechanism is direct trauma, such as falling on the lateral hip. So if we don't have a hip pointer happen, or we could have a hip pointer happen, but then we also have a bursitis flare-up as well. Those two can go together. So signs and symptoms we've talked about: pain. It can be instant inflammation, redness of the area, and then tender to palpation. It can be squishy, and then they're going to experience pain. We can use NSAIDs to help the inflammatory process, ice as well, compression maybe, and then just using massage as well to work out that inflammation. There can be an aspiration done by a physician if needed. Not as common in the hip, and these bursa do not inflame as much as like we saw with the olecranon bursa. So these ones are not drained as often, but they do get irritated pretty frequently. And then we're looking at snapping hip syndrome. So this is a chronic bursitis. It's a condition very prevalent in dancers, runners, and cheerleaders. They may develop secondary to a variety of intra-articular and extra-articular causes. So there's 3 types of this condition. There's external, internal, and intra-articular. External is the most common. It's caused by the iliotibial band or gluteus maximus snapping over the greater trochanter during hip flexion, which leads to trochanteric bursitis. Internal is the iliopsoas snaps over structures deep to the musculotendinous unit, such as the iliopsoas bursa, and then it's causing the inflammation internally. Then we have intra-articular, so these are lesions of the joint, possibly a labral tear, and that can lead to that condition. So we're going to talk about labral tears later. The most common is external, involving the IT band. Snapping hip syndrome is characterized by a snapping sensation rather than a pain. It's either heard or felt during certain motions at the hip. It usually occurs when an individual laterally rotates and flexes the hip while balancing on the other leg. If the iliopsoas bursa is affected, the individual may complain of snapping, chronic pain, or both that are happening within the femoral triangle region. Management of snapping hip syndrome, it's usually healed with limitation of hip motion, particularly limitation of extension by use of an ACE wrap, or we call it a hip spica. Ice and NSAIDs are used to relieve inflammation and pain. If associated with pain or a sense of hip joint instability, then we would refer them to a physician. You can do a rehabilitation protocol to address specific deficits, including muscle tightness. There might be muscle imbalances that are causing this, or poor training techniques that can be corrected. All right, slide 13, sprains and dislocations. All right, so the hip joint does not sprain very often. It's rare because of the multitude of movements that are allowed at a ball and socket joint, but also because the hip provides a big level of protection with all those layers of muscle that add to its stability. So injury can occur in violent twisting actions or in catastrophic trauma when the knee strikes a secondary object. So traumatic, those traumatic ones happen, or the catastrophic ones happen like maybe a car accident. Your knee hits in the dashboard and then forces the hip posteriorly. Traumatic hip dislocations in children are rare, but more common than femoral neck fractures. So we're looking at 2 different things there. And that's largely resulting from the pliable cartilage composition of the acetabulum during the early to mid-teen years. So more specifically, we're going to be looking here at hip dislocations. Because sprains don't necessarily happen. If you sprain your hip, something bigger is going on. So, signs and symptoms. A severe hip dislocation will result in immediate and intense pain and an inability to walk or even move the hip. When you get to an athlete, they will look like the picture that I included on the slide of the football player. They will be internally rotated and the hip will be flexed. The x-ray is a little bit hard to see, but it does show a hip dislocation. But the picture of the football player kind of explains more of what that would look like when you walk up to an athlete. They will go into shock. This is a massive injury and it is an immediate call for 911. You do not move the patient, you do not touch the patient, well, you touch them, but you do not move them. You treat for shock as best you can. Make sure they stay awake. Get them a blanket, don't give them food or water, and then wait for EMS to arrive. Management here, immediate EMS call, you keep them comfortable, you treat for shock, and then they will be transported to the hospital. It will be reduced by a physician, probably under x-ray. And then they'll need to have an MRI to see if any other trauma has happened. Management of these days after, swelling is going to go through the entire leg. So using compression is extremely important. You can do an ACE wrap from the ankle all the way up to keep the swelling from pooling in the feet. You can use units like Game Ready or the Normatex to keep circulation going throughout the leg. Rest, ice, elevation is huge here to keep fluid from building up in the lower leg. I've been an athletic trainer for 5 years, and I've only seen one of these. It was when I was in my second year of undergrad. I was a junior, second year in our athletic training program. And so these don't happen super often. It really depends on the sports that you work with as well. But that athlete did not return to playing football either. So these are catastrophic injuries. They can be career-ending injuries, and they are an immediate EMS call. Okay, now we're moving into strains of the thigh and the hip. So this first one, we're looking at quadriceps strain. So this is less common than hamstring strains. Let's see. An explosive muscular contraction of the rectus femoris can lead to an avulsion fracture at the proximal attachment of the AIIS, but tears more commonly occur in the mid-substance of the muscle belly. So we're going to talk strictly about strains. Avulsion fractures happen more so in adolescence, and so we don't see those hardly at all. Because the rectus femoris is the most superficial muscle of the quadriceps, any disruption is easily visible. It will ball up, or you can see how it spasms to protect itself and all the guarding that's happening. So those are they're very visible quite often. Vastus lateralis and vastus medialis are more rarely injured, but when an injury does occur, those ones involve the mid to upper third of the muscle belly. So they occur higher in the quad than in the rectus femoris. Like I said, we're going to talk about management of strains all at once. So right now we'll just talk about signs and symptoms. Snapping or tearing sensation at the ASIS or at mid-thigh during an explosive movement is going to be a key indicator for a quad strain. Increased pain or weakness will be elicited during passive knee flexion, active knee extension with a flexed hip, resisted knee extension as well. So when you're going through your assessment, you're going to look at those things and measure weakness and pain when doing those. An isolated rectus femoris strain will produce increased pain and weakness during passive knee flexion and hip extension, and then active knee extension and hip flexion, but also resisted hip flexion with the knee flexed at 45 degrees. Because this muscle crosses two joints, we need to test it in a few different ways. Hamstrings, we're on slide 15 now. Hamstrings are the most frequently strained muscle in the body. It's caused by rapid contraction of the muscle during a ballistic movement or a violent stretch. The picture here shows pretty common bruising that happens when you tear or strain your hamstring. Bruising will happen depending on which hamstring you have strained. It will be on either the medial or the lateral side. These happen a lot more frequently down towards the muscle tendon junction of the hamstring, and so that's why this bruising is closer to the knee, is because this is happening more in the tendon, and it tore more towards that junction. Signs and symptoms would be they might have a history of poor posture, they might be very inflexible, or they could have a muscle imbalance. We see this a lot in soccer players. Athletes who are right-footed will be stronger in their right leg than their left leg, and they can have significant muscle imbalances there. Injury often occurs when muscle function suddenly changes from a stabilizing knee flexor to an active hip flexor, so when you're sprinting, and it may occur mid-stride. So they're sprinting down the field, and all of a sudden they reach back, and they just in the middle of sprinting and grab the back of their leg. Okay, we know their hamstring just popped. They'll have a sharp pain in the posterior thigh. They may need assistance off the field or wherever they are. They may or may not be able to bear weight depending on the severity of the strain. They'll have increased pain or weakness during passive knee extension, passive hip flexion, active knee flexion, active hip flexion, active hip extension with an extended knee, resisted knee flexion, resisted hip extension with an extended knee. So if you strain your hamstring, you're in big trouble because you use it all the time for many things. And these last for a while. It could be a week, it could be 4 to 6 weeks, depending on how big of a tear you have. You can treat these also with ice, compression, stim, ultrasound, but we're going to go through management of that. We have one more strain to look at, and then we'll go through management. So slide 16, we're looking at adductor strains or groin strains. So this is common in activities that require a quick change of direction. We also see a lot of these in soccer, mostly when we come back from the summer and they haven't trained as much over the summer, and then they go right into being competitive at fall camp, and then they strain their groin because it's not as strong as it needs to be. Adductor magnus is injured more severely, and mild strains occur more often distally in the musculotendinous junction. And so it occurs more often in like the mid-thigh area, but sometimes a high groin, it can pull really high up, even by the pubic symphysis. So signs and symptoms here would be an initial twinge or a pulling sensation. They might be unable to walk due to sharp pain. They'll have increased pain, stiffness, and weakness in hip adduction and inflection. Side-to-side movements will elicit pain. And then in these, you could have a palpable defect as well. Again, when we're palpating here, we want to be more thoughtful about what we're doing and just making sure that the patient is not uncomfortable upon palpation. Slide 17, we look at management of strains. And so on the picture there, that looks like a hamstring strain, sorry. And we're using KT tape to elicit that lymphatic opening, opening up all those chains and letting things drain out. So an athlete comes to you with a strain, immediate ice, compression, elevation, and then protected rest. Much like the quad contusion that we looked at, we want the injured muscle to be iced in a stretched position. So for the quad, it would be exactly like we saw with the contusion. For a hamstring, we would lay the patient face down on the table, but they would scoop back so that their knee is off the table, and then we're putting their hamstring on a stretch, and then icing it that way. A compression wrap should be worn to prevent a venous thrombus and then distal edema. So sometimes you'll swell throughout the entire leg below the knee. Sometimes it will only swell in the top part of the leg. And so really that's a case-by-case problem. You'll use NSAIDs for the first week to 2 weeks. You can use electrical stimulation to modulate pain. Like we see in the picture, we can use KT tape to help with lymphatic drainage. And so we cut it in the little spider strips like that. And then the idea is that the tape will, the fluid is attracted to the tape, and so it will pull up to the top of the tape where it's still connected. And so we want to pull all of that fluid to the closest lymph nodes. So that would be in the hip. We don't want to pull it distally. We want to pull it proximal to the trunk. So in the leg, we would pull up to the hip. And then we would use therapeutic exercise for stability and strengthening. These strains can last for a long time. And then depending on the athlete, it could be something that bothers them for a long time and it turns into a tendinitis. On slide 18, we look at the different kinds of hip fractures and associated signs and symptoms. Most common that we're going to see in college athletes is a stress fracture or a femoral fracture. And both of those would mostly be nutrition related unless it's catastrophic. If there is a femoral fracture and it is catastrophic, it's an immediate EMS call no matter what. There's just too many things that could go wrong there that we want to get them seen immediately. But you can look through that table looking at the signs and symptoms. They are mostly the same for a lot of these fractures. I've never seen any of them actually. And so I hope I don't. I always hope that I don't see something. But you can look through those, and if that pertains to the injury that you decide to do for your homework, you can use that. All right, on slide 19, we're looking at our last one, which is an acetabular labrum tear. So the hip labrum is a ring of strong, flexible cartilage that rims the outer edge of the hip socket, which we talked about before. It serves the purpose of deepening the joint, and then it also increases the surface area of the hip joint by 21%. So it's pretty important. And then this surgery to fix a tear is actually fairly new, within the last 10 years. So signs and symptoms of a torn labrum in the hip would be popping or clicking deep in the joint, much like the shoulder labrum. They feel like it's catching. They might have a deep groin pain, so at first you might think that it is a groin strain, but by taking a history, by asking questions, we may find that they might have something more going on. They will have an achy feeling all the time, and then they'll feel like their joint is catching within, so it's not moving around smoothly, it's kind of catching, and they have to either pop their hip or they feel like this deep catch, like they can't move it. Management, we would be referred to a physician. There's really not a whole lot that I can do without knowing for sure what's going on. I did have an athlete who was having pain similar to this, and so I thought that her hips might be off, and so she saw the chiropractor. The chiropractor made it much worse, and so it was after that that we decided she needed to be referred to the physician, and it ended up that she had a labral tear. So doing treatment doesn't necessarily, it's not always going to help, but it might also make things worse, which is not always bad. It will help you direct you towards the right answer. You might get the wrong answer, but it's pointing you towards the right answer. Like I said, this is surgical, much like the shoulder. It's arthroscopic, but it's really intense. They dislocate the hip, they work inside the joint. It's a 6 to 9 month recovery for full return to play for an athlete. You can live with a labral tear and not fix it. Some people will have a labral tear that bothers them when they do sports, but when they are done with their sport, after college or whenever that may be, it might not bother them in their everyday life. So if they can compete or without pain, or if they can compete through pain, that is appropriate. It's a choice that they have. It does not always have to be surgical. You can do therapeutic rehabilitation to stabilize the hip muscles, and most common, you have to do glute strengthening. Weak glutes will often lead to a tear in the labrum of the hip. All right, slide 20. We start with palpation. Again, you can kind of do this on yourself, following through. If you have a roommate or someone who is willing to let you practice on them, by all means, you can do that. Just get permission first. So you can walk through anterior palpation and then posterior palpation. And we don't really need to do lateral palpation here because all of those structures are connecting, so we kind of feel them anyway. On slide 21, we look at how to measure active motion. So the picture shows how you would measure hip flexion, hip extension, adduction, abduction, and then also internal and external rotation of the hip. On this slide, you also have degrees. We also need to remember that a lot of these muscles cross two joints. So bending the knee may increase your range of motion by a lot. It might decrease your range of motion, so we also need to keep that in mind. On slide 22, I've given you pictures of how to test resisted range of motion for muscle weakness in the hip. And then it also gives you positioning for what you as the clinician should be like, and then how the patient should be positioned as well. So if you want to practice on those, you can. I just wanted to give you a visual there so that you can see what we're looking at. On slide 23, I list a few of the hip special tests, stress tests that we would do. With the hip, there's only so much that we can do. I know as a clinician, I'm not going to diagnose a hip injury. And so what I am doing is I'm trying to get a ballpark. I'm trying to find some explanation for an athlete's pain, and then we will try a therapeutic process for 2 weeks, see if things get better, see if their pain subsides, and if it doesn't, then I would refer to a physician, because I know I'm not always going to get the answer. So the pictures on the slide will tell you which tests we're doing. So on the top left, that one is Patrick's test. On the middle picture on the top is the sacroiliac rocking test. The picture on the bottom where the knee is at 90 degrees, that's the sacroiliac rocking test. And then the one where she has her hands on the hips, that is the sacroiliac compression and distraction test. So you do that one this way, and then the middle one where she has her hands on top, that is it's actually distraction. So here she's doing compression and she's compressing the SI joints, and then here she's doing distraction on the SI joints. It sounds reversed, but that's exactly what she's doing. And then on slide 24, our last slide, we're looking at special tests of the hip. We can look at things that would lead us to refer to different things. So like I said before with my athlete, I referred her to the chiropractor because I found that she had a leg length discrepancy. And so that is one test that we would do to measure if their ASIS are in line, if their medial malleoli are in line, and that might be because the hip joint is off a little bit. The Thomas test for flexion is testing the rectus femoris and tightness there. The straight leg test is testing the hamstring for flexibility, but also it can be a test for neurologic symptoms. Again, if there is hip pain, it's often concerning, and so we would refer to the physician for most of these. If you guys have questions, let me know. You do have a homework due for this in a week. And so we're winding down on the quarter. If you guys need anything, please let me know. I love seeing your homeworks and what you're working on. I'm very excited to see your final projects. And I hope to keep talking to you guys, and stay healthy, stay safe. The rain stopped. It's gorgeous again outside today, and so I hope you guys are enjoying it.